Gentlemen, if I could ask you all to come in and sit down. We're about to move on to the next session. And so, without further ado, I'd like to introduce Kristin Verbeke and Daniel Pohl, who are going to introduce themselves a little more, and then they're going to move into this late morning session. Thank you very much for your attention, and do come in and take seats.
Good morning, everyone. Also from my side, I'm Daniel Pohl from the University of Zürich, head of neurogastroenterology. And Kristin, please.
Thank you. Good morning, everyone. My name is Kristin Verbeke, and I'm a pharmacist in the University in Leuven hospital, where I'm responsible for the breath testing.
So this is going to be a nice session, because I think breath testing is something that a lot of people do, where there is always little consensus, but our patients like it, also actually our nutritionists like it. So I think it's very worth discussing this at extenso, and it's our pleasure to introduce the first speaker, Heinz Hammer from Graz, Austria, who's someone who really was a driving force between the recent European and associated societies international guidelines for hydrogen breath tests. So please, Heinz, enlighten us.
Yeah. Thank you, Daniel. Thank you, Kristin. Now, in order to, after this nice break we had with coffee, tea, some sweets, and outside in the nice sun, in order to get our minds back to the scientific road and scientific thinking, I'm starting out with the obvious. What is the obvious? Why would, The obvious is, as in any guideline, we start out with thinking, why is there the need for a new guideline? In this case, for a new breath test guideline? Well, it's the usual, the common, to improve harmonization of diagnostic approaches, in this case for the assessment of functional GI symptoms and disorders, which are, as Daniel said, very common in specialist and primary care GI practice, to provide physicians with the information required to deliver high-quality care and to communicate the best care options to patients. This is true to every guideline. And to allow a more rational, evidence-based approach to diagnostic evaluation and treatment. And ultimately, goals which guidelines always bring with them is, guidelines shall facilitate cooperation between expert groups and the performance of multi-center clinical trials focused on the management of a variety of GI diseases. So these are the two guidelines which 4 European societies and associations cooperated on. We had the breath test group of 45 participants from 18 European countries marked there in black, and those were two guidelines who came out of this effort for breath test guidelines. The one is the left one on hydrogen and methane breath test, which I will be focusing on now. And the second one was the European guideline on 13C breath test, which is not focus of this presentation. The methodology we have used for developing guideline statements and recommendations, and we made a distinction between what is a statement, what is a recommendation, has been published in Digestive Diseases, and we hope that this may sort of, everybody who does guidelines, who starts out guidelines, always thinks, well, how shall I do that? We look into the literature. How did other people do that? And in fact, we see guidelines are done very, very differently. So it is a very hard way for any group who wants to start a guideline how to approach it. And this is the reason why we published our procedure, which can be looked up. Now, within the last 20 years, there have been, before our European guideline published in 2022, there have been 3 other guidelines concerned with hydrogen methane breath tests. This was the German guideline published in 2005. This was the Italian published in 2009, and then the North American in 2017. They all had a little bit different approaches. different topics. For example, pediatric patients, which our guideline included by including the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, only was covered in the Italian guidelines, but not in the other ones. Methane was a part of the topic in the Italian, North American, and then again in our guideline. Recommendations and statements focused in all of these guidelines on methods, on carbohydrates, on SIBO, OCTT. The German guideline also included in this publication C13 tests, which we had in a separate guideline. And it was only the Italian guideline, which in the past had also included discussion and a focus on symptoms, which again, we have picked up by focusing on the differences between what is and definitions, what is malabsorption, what is intolerance, and why is it important to distinguish between those two. I will focus now on two major topics, carbohydrates and SIBO. And before that, I will shortly raise the issue of methane measurement. Should we do it? Is it too expensive? Does it get too complicated for the patients? Is it any helpful? And we had covered this methane issue in two parts of our guideline, and this was in the general recommendations part and the methodology of the breath test. And again, then we have two as one statement and one recommendation in the carbohydrate part of the European guideline. Now, what did we come out in the general recommendations part? Measuring breast methane excretion, if available, may be helpful in patients with low hydrogen excretion and or lack of clinically relevant increase in breast hydrogen after ingestion of a malabsorbed substrate like lactulose. I indicate, you will see statements and recommendations like this now in several slides, and I indicate quality assessment by Q, which this statement only has a quality of a D, which is poor quality behind it. And I indicate the agreement rates and disagreement rates when you see these statements. The second statement which I want to bring to your attention here is measuring additional gases like carbon dioxide or oxygen, which some instruments do offer. Again, if available, we do not drive you into buying new machines which offer you these gases, so don't throw away your old machines, but if available, may be helpful to confirm that end expiratory collection of breath is correct. With regard to testing of carbohydrate malabsorption, we had the statement that the role of inclusion of methane measurements for improving clinical usefulness of hydrogen breath testing for detection of clinically relevant carbohydrate malabsorption is unclear. Increased sensitivity may be counteracted by decreased specificity with 84% agreement. And another recommendation, if methane measurements are used, then we recommend to use a methane cutoff of at least 10 ppm increase over baseline to indicate malabsorption. Now, focus on carbohydrate malabsorption. To remind all of you what happens, carbohydrates which escape absorption in the small bowel and which reach the colon then are metabolized there by bacteria to form, among other gases, hydrogen. Hydrogen then is absorbed in the colon and excreted in breath. However, we also have symptoms which we associate with carbohydrate malabsorption, and this is then related to the term of carbohydrate intolerance. Now, we in our guidelines suggest breath hydrogen and symptom measurements to be obtained before ingestion of the tested substrate, and then in 10 to 30-minute intervals for up to 5 hours. Now, along the line, and we have a timeline here, a timeline indicating guidelines 2005 until 2017. Now, this was the guidelines of the past, and the discussions. And I come into parts of this, a discussion by Suarez and Mike Levitt's group, by Suchi heading the NIH consensus group in 2010, and this should be, in fact, 2019, where there was another discussion going on, and I'll indicate what it is. I just want to bring to your attention a timeline which indicates that along this timeline over 20 years, we had several guidelines, but discussion about usefulness and about indications and so on never really had stopped. Now, what was it that in 1997, Suarez and Levitt said, if the breast test is to be considered clinically useful, it must identify a condition that results in appreciable symptoms. It must be shown that lactose in the quantities commonly ingested actually causes abdominal distress or diarrhea. And there may be very little need for subjects to be clinically tested for lactose malabsorption, since this test identifies a condition that rarely produces symptoms. Now, again, to remind you of the guideline, this was here. Thereafter, the German and the Italian guideline were published. And in 2010, the NIH consensus stated that lactose intolerance is a real and important clinical syndrome. Most people with lactose malabsorption, however, do not have clinically lactose intolerance. Many persons who think they are lactose intolerant do not have lactose malabsorption. This was, if you look at the timeline here, right after the publishing of the German and the Italian guidelines. And several years thereafter, after this NIH consensus, then the American guideline was published in 2007, and this still and again did not finish the discussions. And Mark, my brother Johann, and myself found identified the necessity that we have published the 10 mistakes in the management of carbohydrate intolerance and how to avoid them. And this is a UEG publication. And I indicating here 5 out of these 10 mistakes. Mistake number 3 was assuming that the mechanisms underlying intolerance are completely understood. Number 4, not considering the role of all poorly absorbable fermentable carbohydrates in patients with suspected carbohydrate intolerance. Number 6, putting too much trust in breast testing. Number 7, misinterpreting lactase deficiency or malabsorption as lactose intolerance. And number 8 is relying on unvalidated symptom assessments. So we found the necessity for another drive at, in this case, European guideline. Now, what is the focus of these guideline statements and recommendations with regard to carbohydrate malabsorption and intolerance? We define and distinguish between malabsorption and maldigestion on one side and intolerance on the other side. We focus on the relation between malabsorption and symptoms. We identify validated symptom assessment tools for carbohydrate intolerance in adult and pediatric patients, the ACPQ and PCPQ. We recommend to combine malabsorption testing with validated symptom measurement in adult and pediatric patients. And we come to recommendations on future tests. For those who do not know these questionnaires, this is a graphic depiction of the adult carbohydrate perception questionnaire. It is validated, it has been published, it is on a visual analog scale. And in the meantime, there was an international group which has produced validated translations following a Rome protocol for translation of questionnaires to Bulgarian, Russian, Slovenian, French, Polish, Italian, Romanian, and Hungarian. This is for the adult carbohydrate perception questionnaire, and there are additional translations in other languages for the pediatric carbohydrate perception questionnaire. And also this process of how these translations were performed has been published as a methodological paper. Now, some of these recommendations and statements relating to carbohydrates, one of these statements is that the result of hydrogen breath testing with symptom assessment for lactose malabsorption and intolerance have acceptable sensitivity and specificity for a clinically relevant condition and can direct effective therapy. Minimum reporting criteria of a breath test used to detect carbohydrate maldigestion or malabsorption should include a statement whether there is evidence of maldigestion and malabsorption on one side and intolerance on the other side. The recording of symptoms manifesting after carbohydrate ingestion is an integral part of a carbohydrate challenge test. And this is also reflected in the pediatric statements. In our guideline, the adult statements, which are true both for adult and pediatric, have just a number, and those which are only applicable for pediatric patients have the bed as a part of the statement title. And this is a very important statement. The combination of carbohydrate breath tests with symptom assessments allows for the determination of 4 different entities after a carbohydrate load. The first one is maldigestion or malabsorption plus symptoms. The second is maldigestion or malabsorption only, that is without symptoms. The third is symptoms only. And the fourth is none of the above. Healthy, so to say. Abdominal symptoms may arise after carbohydrate ingestion without objective evidence of malabsorption on breath tests. This may be due to false negative malabsorption tests or other mechanisms not related to malabsorption, such as a nocebo effect, the food allergy, or other mechanisms which have not yet been clearly described, and this entity certainly needs further studies. So, we have identified future research needs, clinical research in the detection and treatment of specific intolerances, for example, in IBS, therapeutic trials in patients with documented intolerance, not malabsorption, intolerance, to improve knowledge about the rational use of treatment options. Studies to address whether in diseases like IBS, the treatment of specific carbohydrate intolerance, a dietary precision knife approach, surgical knife approach, will improve the patient's quality of life, costs of living, long-term safety, and health outcomes as compared to empirical and less specific broad dietary advices, dietary shotgun approaches like a general reduction of poorly absorbable, fermentable monosaccharides, disaccharides, and polyols. We need studies also to examine to which extent validated measurement of symptoms of carbohydrate intolerance will find a place as an adjunct or even a replacement of hydrogen breath tests. And for the future, a project on the development and application of app-based validated symptom questionnaires to assess carbohydrate intolerances. So for the carbohydrate intolerance, and that's not the finishing of my presentation yet, although it's a go-home message, it's just for carbohydrate intolerance, symptom assessments with the local version of the ACPQ should be included in carbohydrate malabsorption and intolerance testing. Treatment with diet or supplement shall be restricted to patients with documented intolerance for the time being, and until we get more in-depth studies on that. Patients with IBS-like symptoms shall be tested for intolerance to specific carbohydrates, and based on these specific dietary exclusions rather than broad dietary restrictions, also a provocative hypothesis which needs to be clearly studied in the future. Now, a few slides about testing of small intestinal bacterial overgrowth. There we have a little bit a different challenge. Here it is, the carbohydrate being approached by bacteria, mostly ascending from the colon into the small bowel. So hydrogen being produced in the small bowel and then excreted in breath. Until a true gold standard is established, and that's what the recommendation 3.4 of the guideline says, hydrogen breath testing can be used for the diagnostic evaluation of SIBO. Evaluation of SIBO with a hydrogen breath test can be considered in the presence of symptoms described here, in the absence of another diagnosis on endoscopy or imaging, especially if there are underlying conditions which increase the risk of SIBO, that is a moderate to high pre-test probability. And there are a few more statements. Hydrogen breath testing with lactulose or glucose may result in false positive diagnosis of SIBO caused by rapid transit with early colonic fermentation of the substrate. The diagnostic criteria for the diagnosis of SIBO using breath testing have not been confirmed and uniformly accepted, and the clinical relevance of a positive result needs to be considered in the light of the pre-test probability of SIBO in the individual patient. The use of hydrogen breath testing for diagnosis of SIBO is non-invasive, safe and inexpensive. However, the interpretation of results is limited by important confounding factors, in particular variability of oral-cecal transit time, and the risk of a false positive or false negative hydrogen breath test for SIBO can be reduced by combining breath test with independent measurement of OCDT, like scintigraphy. Which leads me to the last slide. So general comments on the use of hydrogen breath test for diagnosis of SIBO. The guideline refrains from requesting the routine use of scintigraphy in combination with breath test because scintigraphy has a limited availability. No discussion about that. And if a breath test with concurrent scintigraphy is not available, two options remain: either interpretation of results based on pre-test probability or serial test with hydrogen breath test being followed by a transit test. Thank you for your attention, and I want to use this auditorium here again to thank all of the collaborators in the guidelines, some of them sitting here on the podium, both of them, because Kristin contributed to the C13 guideline and is chair of the meeting, and I've seen others around here. Thank you to all of you.
Thank you, Heinz. I think we have time for a short few questions. Please go ahead.
Thank you very much for your lecture. I think it's very enlightening. I have my name is Ishai Ron from Tel Aviv, Israel. There are inherent, I would call mistakes or disadvantages, especially for SIBO testing. If you use the glucose is completely absorbed usually in the duodenum. So if you do not have a large diverticulum in the duodenum, which may cause real SIBO, then you probably get a false negative results. As for lactulose, which is, I think, the most of a problematic, it has an inherent mistake. It's an osmotic laxative, not absorbed, usually absorb water to the lumen and increases the small bowel and the large bowel transit. Are there any in the foreseen horizon, any other substances which could overcome these limitations?
Yeah. What you said is right on the point. I can agree with you fully with your interpretation of the limitations of using glucose and lactulose. And maybe for SIBO, we would have, the gold standard, the perceived gold standard is doing aspirations, which again may be limited to parts, reachable parts. Although, like in the past, we had used tubes which had a mercury bag, and then you could have them transported by all the way. So I say we have used, and there is a reason why I'm talking in the past tense. So maybe it is like without doing a provocation, by adding a carbohydrate, because in fact we really need the carbohydrate to provoke the amount, the volume of hydrogen being produced, because there are so many steps in between until the hydrogen is excreted and can be measured there. So maybe it is without provocative carbohydrate to measure hydrogen with a gas-sensitive capsule along the GI tract and establish normal values of what a healthy person would have in hydrogen concentration in the jejunum, in the ileum, and what in SIBO would be. This is a hypothesis which we will see whether this works out. But this would be the way I think would be reasonable to go.
If I may, what about methane? The American guidelines, or perhaps not the guidelines, but certainly recent recommendations from certain prominent authors almost suggest that methane is always pathological. And as we know, sometimes methane is present before we start the test at above 10 ppm. Sometimes it increases, but not necessarily in correlation with the symptoms that we see, not that sort of typical pattern we like to see with hydrogen. How should we use the methane information if we obtain it?
Yeah, this is really unclear. Methane is a product of certain populations of our intestinal microbiome. A very important population which produces methane is archaea, and we have recently published a review on the role and function of archaea and also how you can treat it in Nature Gastroenterology half a year ago or so. So we have certainly a population of archaea, which 20 or 30% of the population are methane excretors, and which is there constantly. But then methane is also produced out of hydrogen by hydrogen-consuming and transforming bacteria and archaea. So you also get an increase in those people who have the methane-producing microbiome. Then if you add a substrate which adds to hydrogen production and which then serves as a product for methane, then methane may also increase after a hydrogen breath test. Now, after a carbohydrate load. Now, within the challenge of hydrogen breath tests, methane is assigned a role to identify a group of patients who are hydrogen non-excretors, which may be up to 20%, who after giving lactulose, from which we know 100% of lactulose ingested reaches the cecum, so 100% of persons, healthy persons who get lactulose should have an increase in hydrogen. But only 80% do that, because we always thought these may be methane producers and that measuring methane might identify those falsely negative hydrogen excretors who have malabsorption but do not increase the hydrogen. But that's not only the case. Still a part remains, and there are other metabolic pathways leading to sulfate reduction and so on. So, and this is for the breath test. So this is purely of diagnostic purposes. The other part is the biologic effect methane might have. It might have it on the neuromuscular function of the GI tract. But that is still unclear. Is it related to constipation? Yes or no? Cause or effect? Hen or egg? That remains unclear, the relation. And this would be the methane as a constant level. For this, you wouldn't need the breath test or the provocative testing.
Thank you, Heinz. This is obviously a topic where we can discuss a lot longer, and I think we can do that maybe later. But thanks you for the stimulating talk. It's my pleasure to introduce the next speaker, Clive Wilder-Smith from the Hirslanden Group in Bern, Switzerland, and he'll give us his take on the assessment of carbohydrate malabsorption and intolerance and what he believes which tests make sense and what we can actually learn from them. Thank you, Clive.
Thank you. Sorry, how do I get to my slide? There we go. Wonderful. Thank you so much. Thank you, Mark, for inviting me to speak on this topic. Thank you, Heinz, for laying excellent groundwork, which will allow me to skip some of my slides. So my topic I want to remind you is which tests make sense and what we can learn from them. So this is a more personal review of the developments in this area. Having been in the area for quite a few years, I have no disclosures to make except one, really, which is that I eat carbohydrates every day in high concentrations. And I suspect you too have a conflict of interest because up to 20-25% of you will have intolerances after having ingested carbohydrates. So why are we interested? Now, Heinz has given us a few reasons why we may be interested. But these are my interests, really. We're looking at clinical effects of altered absorption and related fermentation. So I think it's important for us to anchor this discussion to outcomes, right? So we can look at tests, mechanisms, and so on, but is this clinically important? That is part of my talk. And then we're looking at more mechanistic things, which measures of malabsorption and clinical applications, but specifically now mechanisms of fermentation by microorganisms to gaseous and non-volatile metabolites, where we are looking forward to the next presentation by Peter Gibson. So definitions, we've looked at these definitions. I just want to point out that in these definitions, we are looking at objective tests, which we measure, and then we are looking at very subjective measures, which are the questionnaires, which Heinz Hammer will talk about more. The outline of my talk will be this. You see that there are quite a few points, so I'm going to be brief on some of them. We have the methodological issues and assumptions. Some of the assumptions we've talked about in our discussion already, and then clinical issues, and maybe just the slide directions for the future. So carbohydrate tests, there are a few we can choose between, but by far the most commonly used and explored ones are breath tests. So I am going to be talking about, in contradistinction to other sessions here during this week, some very old technology. It's old, barely adjusted, barely adapted. So this, in a sense, makes the topic less interesting, maybe, but we need to learn whether these old tests should be abandoned or whether we should still use them. And of course, the history goes back a long way. We go back to the 70s, where I should have mentioned Levitt, I suppose, who was very early in this area. And then, Rumison was, of course, very exact in looking at the function of breath tests, looking at symptoms as well as signs of malabsorption. I'm not going to be covering extensively any of these areas that I list below because time is too short. We might look at those in discussion if we have time for that. So we're looking at this age-old test, the carbohydrate breath tests. Now, mechanisms I don't really need to dwell on much because these will be familiar to you, where we have fermentation of different poorly absorbed or better absorbed sugars or carbohydrates, and then we have metabolites forming volatile and non-volatile, and then we have effects on the GI tract. We have primary and secondary causes of malabsorption and maldigestion, which you will be familiar with clinically, taken from a recent table here. But this is important for me as a background for the understanding, because this explains why we have so much fuzziness in our tests and the results and the validation. So what I've shown here is a schematic representation of the gut, the small intestine and the large intestine, and the assumed bacterial concentrations. And then we have, this is not mentioned much, but we do have somewhat of different areas of the small intestinal tract that are more likely to absorb the different sugars. So here I've color-coded glucose, for example, being absorbed very early in the duodenum and a little bit of the jejunum. And at the other end here we have the presence of sucrase in the intestine, which is lower down. So this is not considered much, but it is important, theoretically at least. The other thing I want to talk about or mention here is that we have these theoretical numbers here, but of course we have a spectrum that differs from each in each publication, in each individual. The spectrum is here, so to say that SIBO begins here or here is actually a very arbitrary assumption, because we actually have a spectrum of colonization there. And then fermentation leads to gas in the intestine. And again, Peter Gibson has done some wonderful work showing that what is available in the intestine is not what we see in the breath. So there we have a potential problem, and we have other metabolites forming. So we have determinants here in the breath test that relate to GI transit, the microbiota location, composition, and activity, the diffusion potential into systemic compartments and then into our breath, and increasingly the effect of sensation. So let's just keep that in mind. There we go. So I'm going to just highlight with statements and some figures, some major methodological issues. We've talked about malabsorption versus intolerance, and we see that if we look at existing studies, the data is very fuzzy and the numbers are very high. So there's a moderate association between malabsorption and intolerance in most tests. If, for example, we summarize tests that have looked at both, we see that malabsorption occurs alone with intolerance in between 5 to 55% of patients. On the other hand, intolerance alone, symptoms alone without malabsorption, 2 to 42%, huge range. So the need there is clearly for standardization of test details, subject selection, because these are different subject groups, questionnaires. So a lot of the earlier studies have concentrated on malabsorption, which means that some of these tests need to be reinterpreted in the light of the importance of intolerance. And so we are probably measuring related but different processes. Illustration here, some beautiful work from Mark Fox's group that most of you will be aware of in Chinese patients, where I just want you to look at this group here, lactose intolerance and the numbers here, dose-response relationship, and lactose intolerance, the symptoms here, and we see there's a huge difference across the doses between the numbers here and here, both in IBS patients with diarrhea as well as in controls. Just to highlight for you to see that there is a colossal difference between these two terms. I just want you to look at a large study of our own, here we go, of our own. Just look at the red box at the bottom. We looked across different functional GI groups. We had over 1,300 patients. In the intolerance percentage there, we see the prevalence of intolerance is 31% across all FGIDs, malabsorption around 16%, and an overlap in 13%. So these figures again show us there is a difference. Looking at false negatives and positives, Heinz has laid the foundation for that, so I'm not going to go through this in great detail, but we see, just looking at the figures here, that false positives in different studies, 5 to 55%, we have raised gas concentrations that are inappropriate. False negatives, on the other hand, we have 20 to 30% in studies. False positive symptoms or false positive intolerance results where we have a nocebo or hypervigilance effect could be 10 to 25%. We ourselves looked at the necessity of blinding and showed that with a fructose intolerance test, we don't need to blind. But this may be different in lactose. False negative symptoms, really reporting issues, standardization issues, and we again can point to the beautiful questionnaire that has been shown before. Now, we looked at repeatability, and I would say that there are very, very few studies looking at the repeatability of breath tests, and it is moderate. For the fructose test, we looked at the fructose test with ICCs of 0.7, 0.6, really 0.7 for the symptoms, 0.6 for hydrogen methane concentration, which is barely moderate, but it is still moderate and compares to some tests that we use in medicine. But we have repeatability that is moderate. Use this. Is methane testing helpful? We've looked at this, so I'm not going to actually look at this, but maybe that last statement is quite useful. Methane changes classification in lactose malabsorption in 5 to 15% of IBS and controls, so you might want to just bear that in mind. Small number, but it might be relevant in some of your studies. SIBO we've looked at. Glucose, according to current data, seems to be better than lactulose for SIBO testing, but they have their problems. Hydrogen breath testing for oral-fecal transit times. Yeah, the data basically is not looking very good there because of many influences of lactulose on the transit times. Maybe a combination with C13 tests will help us, but we will hear more about that in other sessions. So this is the meat of what I want to say in just the few minutes that I have. Do these tests make clinical sense? Now, in that question, there's actually a lot of interpretation and further questions. There are different levels to this. If we go to one level that really concerns me is, do results translate into improved outcomes in disorders of gut-brain interaction or functional bowel disorders? And the best link that we have is, of course, at the moment, are the low FODMAP diets, which themselves have quite a few of fuzzy areas, like how's the dietary advising performed, how is it reported by our dietitians, these kind of things. So we are attaching fuzzy breath test results to a fairly fuzzy outcome marker, although we can now say 50 to 80% in the latest large meta-analysis of IBS patients will respond adequately to a low FODMAP diet. So the real question could be phrased differently. Do breath test results predict outcomes of dietary modulation? And there is some data out there. The data is not very high quality, but I just summarized this in my personal walk through this history, and I only have a few minutes, so I need to summarize this as my personal view. My personal view is that malabsorption demonstrated by breath test results is not predictive of responses to either selective diets that we have, say in lactose, we have a lot of data, or in the low FODMAP study, where the low FODMAP diet, where we have little data actually linking breath tests to the low FODMAP diet. But the data that we have is negative. So breath tests do not predict, as far as malabsorption goes, responses to diets. Now, intolerance to symptoms are not clearly predictive, and there we have a dearth of data. We have too few data to really make a strong statement, but the data that we do have tell us that breath test gas results are not clearly predictive of response to data. I think we need to take this as work in progress, and we could discuss this for hours looking at data, but that is where I believe we stand at the moment. So a positive breath test, and David, you were saying this, a positive breath test may be helpful in motivating patients to try the diet, but we need to rethink the role of breath tests overall. But they are motivated. If you have a patient, you stick them on a breath test and they have horrible symptoms, they are motivated. They believe that this could be useful, the diet could be useful. And this is not to be neglected as a factor in clinical practice, but this is not something we can easily assess in studies and in sort of the scientific role. So we do apparently have a paradigm shift. You don't need to read through all of this, but I wanted to create an impression, and the impression that we see distinctly that actually started, this is a highlight of papers, and if you're an author of another paper and I haven't listed you, sorry, I need to restrict this to a decent font size. So, we're looking at data from 2007 here, and then progressing through history. What we see more is the link between intolerance and indications of hypersensitivity using different tests. But this is now a very interesting link where we might see a role of breath testing and relating to intolerance and hypersensitivity. And this is a study I've forgotten actually I performed, but to me this is a very intuitive study, which I just need to mention a few facts relating to the study, but it will be intuitive. So we looked at over 2,000 functional GI patients, and we used a clustering analysis technique here, kindly performed by our Danish colleagues. And so we had this huge group of patients, and we asked the question, could we cluster these patients into clinical groups based on their clinical symptoms, right? So say their clinical symptoms. And we found 6 clusters that were very different. So we looked at GI symptoms, central nervous system symptoms, musculoskeletal symptoms, history of allergy, and self-rated intolerance scores, right? And we see these clusters. This is now normalized to a scale of 0 to 100. And we see very different clusters. We see this multi-organ group in red. They have everything, right? They have everything. And then we see a group here, this cluster here, that only has GI symptoms, really. They're the fermenters, right? So we have these fermenters, basically men who bloat after meals or ladies, and then we have multi-organ patients. So we were able to show that we have 6 very different groups of patients. And then we looked at the results of breath tests in these patients, right? We looked at the gas results for these clusters, and then we looked at the symptoms induced during the test, so the intolerance symptoms. And lo and behold, what you see is hydrogen and methane do not distinguish between these clinical clusters at all. So in these clusters of large numbers of patients, the breath test does not add any value in the distinction, whereas these are highly significantly different between the different clusters. So this again shows us that the intolerances that are induced during the test are probably relevant for us, whereas the gases are not so much. So we have a paradigm shift. Again, you don't need to see the details here, it's meant to be complex. So we now have a complex picture, right? Where we see that at the intestinal level, we have fermentation going on. We have fermentation going on at the bottom here with the microbiota, leading to changes in the intestinal barrier, leading to changes in immune activation, in the immune system, leading to changes in the central nervous system, be it descending modulation of impulses or being local neuroenteric changes. We have changes in the stress system. So we have a complex interdisciplinary system now relating carbohydrate fermentation to symptoms. So this, again, makes our field interesting after these boring old breath tests. So our future direction could lead into an integration of downstream and upstream investigation of what's going on in fermentation. Something we do very practically here in the food-related fermentation. On the right, we see different bacteria, different yeasts lead to different products, and these products lead to different effects in us, right? So a little bit similarly, I think we need an integrated approach where we tie carbohydrate provocation into the wealth of data we have on the gut-brain axis. And that is where I'm going to conclude. Thank you for your attention.
Thank you for your view on this and a very nice presentation. Open to discussion. So if I may start, Clive, I think you have mixed feelings about breath tests, right? I could hear some positive and some negative notions. So how do you personally select your patients? Who do you offer a breath test, and then which breath test do you offer?
Disclaimer. I'm a practicing gastroenterologist. I'm in private medicine, which means I'm not at an academic institution. I see patients who come off the road, who come from GPs. So the spectrum of patients I see is a little bit different to what you might see in a tertiary care center. And that, of course, colors my selections. I have patients who come in with severe symptoms and they relate it to food. They want to know. And they might come with an idea that it's fruit or it's fructans, or they will have read a lot, or they will talk about histamine a lot. So I have the role of proving to this patient that something is relevant or not. And that is why the breath tests for me are partly important in that issue of the patient needs to feel that something causes their problems to believe in it. Right? And if I can show them in the breath test, that is helpful. But if I look at the data that we have, and granted, many of these studies are fairly small. So, but if we look at the thousands of patients we looked at, that I saw every patient myself, the story is fairly clear that malabsorption is not helpful, but the symptoms we induce during the breath tests are helpful on different levels. So the paradigm shift is, I think, we need to look more at the symptoms we induce during the breath test, but the gas, I reckon, is not so important. That is also colored by my strong feeling that SIBO is more of a epiphenomenon than a true disease, which fits into the fermentation spectrum.
Yeah, I think this is a notion that also was highlighted by Heinz in his previous talk, that that symptoms are probably the thing we'll need to look at. And a lot of our patients, and still our colleagues also, come to us and they talk about lactose intolerance when really they mean malabsorption. And then obviously this is also very much based on ethnicity. So there's really groups where you don't need to do the tests because the ethnicity is going to tell you more precisely how the absorption status of that patient is, right? So symptoms, I guess we believe that we need to look more at that, and also grateful to the work of Heinz and Johan that looked at especially the validation of symptom questionnaires, because that's the next thing, right? How do you measure these symptoms, and what do you make of them? So thank you. If there are no more questions, for the interest of time,
So time to go on, and let's move from the gases that occur during fermentation of carbohydrates to the other bacterial metabolites that are produced, mainly the short-chain fatty acids. And we will listen to Peter Gibson from Monash University, how we can use them as therapeutic and diagnostic tools.
Well, thanks very much for asking me to talk about this, but unfortunately I don't think I've got any very good news for any of you. I have no relevant conflicts in this area. Let's get the right. This one, wrong way. There we go. Okay. I thought that first of all I give a primer in this, short-chain fatty acids 101, because it's a very confusing area, and the first thing, definitions and nomenclature are very confused in the literature. They also called volatile fatty acids, although that probably refers to more things than just short-chain fatty acids. They're linear carboxylic acids, but the definitions can be between 1 to 6, 2 to 6, or 2 to 4. And I particularly like the definition given by Wrong et al. Because I think they're probably right, and it says 2 to 4. But there are also different names, and any of you who get into the metabolomic literature, I used to get confused. I said, where's the butyrate? Where's the propionate? And in fact, because the true chemists use the IUPAC definitions, and so formic acid becomes methanoic acid, acetic acid, ethanoic acid, and so on. So this is one little confusing area that is not resolved. The other thing is, where do branch-chain fatty acids fit in? And sometimes they fit into the definition, but probably should be considered separately. Branch-chain fatty acids have methyl branches. And interestingly, isobutyric acid is not 3-methyl-butanoic acid, but it's 2-methyl-propanoic. It's very, very confusing. I'm going to use the common definitions. And it doesn't include organic acids like the oxyacids, lactic acid, or succinate. Now, it's very important to, if you ever want to work in this area, to know that that's supposed to be a nose there. That everyone knows that acetic acid has a smell of vinegar. Butyric acid has the smell of rancid butter. And I can tell you, because I was doing an enema study, I had bottles of enemas in my office and no one came to visit me because it diffused out. And the other thing is that the isobutyric acid smells like old mutton. So these things are very important if you want to do studies in the area. The sources of them, for us, bacterial anaerobic fermentation of carbohydrate is the source, the major source, but also these things are in food. And in Australia, kombucha is very popular, which is quite rich in short-chain fatty acids. And protein fermentation is the source of the branch-chain amino acids. Now, the pathways in which they're produced are well defined, and it's just that more bacteria can produce acetate than butyrate and propionate. They're more specific pathways. So we end up with in our bowel about 60% of our acetate, 20% butyrate. It should be 20% propionate, not 60%. And so that's just, it's all quite straightforward there. The other thing is that the really fascinating thing about short-chain fatty acids is that they have these amazing number of ways in which they can affect cells. And they can be taken up via simple aquaporin pathways or through monocarboxylate transporters as whole short-chain fatty acids, or they can bind to G protein receptors which have many signalling cascades. So the consequence of this is that butyrate has multiple effects. And it's a double-edged sword, because it can affect so many things. And I made most of my early career in the 1980s, 90s, last century, identifying many of these sorts of things that occur. But the other thing that you have to remember is that these things induce apoptosis. And in the lab, the sorts of concentrations you see in the feces, no cell can survive. And because what the cells in the epithelium are exposed to is not the concentrations that the lumen has, because there's a dilution towards the epithelium. Okay, so with that sort of confusing start, can they be used as a diagnostic test? And the thing is that we would measure it in feces or blood. Now, there are multiple measurement techniques, and it's very hard to find two papers that have the same technique, but they should be measuring the same thing if they're well controlled. But the important thing is that some of them are very complex, some of them are simpler. They need technical skills, and it's not the sort of thing you want to take on if you're an amateur laboratory person. The other problem that I've always had is that there's the veracity of what you're measuring in feces is probably not good. The first issue is that if you take some feces and there's some carbohydrate, still a fermentable carbohydrate left in the feces, and you leave it on the bench for an hour, your fermentation will go on. And so what happens is that then you're in the body, the fermentation occurs, and the fatty acids, the short-chain fatty acids, are absorbed, whereas in the lab they remain in the sample. And so this is something which is very important to remember. Some people have used, we always used freezing immediately that people pass them, and we provide portable freezers, but is 4 degrees centigrade enough? Some studies use that for 24 hours. There was one Indian study where they froze their specimens within 12 to 24 hours, and I think in the ambient environment in India, there'll be all the fermentation will occur ex vivo. There's no standardisation of any of this. The second thing, which I don't think has really been very well studied, is that these are volatile, and what we probably should do is alkalinise these feces first, or lyophilise them, freeze dry them very quickly, and that really has had very little in the way of study. And the other thing is that like anything we measure in the feces, if there's a high content of fecal water, then you will get differences. So if you then look at all of that, what do people do? There's no uniformity in about what happens once the feces pass the anus. There is rarely applied anything about volatility, and rarely does fecal water come into the estimations. So this has all got to be considered when you look at the results of studies. So can it be used as a diagnostic test? Well, I just put up these things which I've actually borrowed from work from last century from experts in this. The 95% of short-chain fatty acids produced are absorbed. So all we're doing is measuring the 5% that's left. And the factors that influence the luminal concentrations include the rate of production, which is what we really want to know about, but the rate of disappearance by absorption, and that's usually very rapid. Any of you who've got a bit of butyrate on your finger or a bit of vinegar, you know that it gets in there very quickly and stays, and it's very well absorbed. The speed of transport along the bowel affects it, and as I mentioned, the ex vivo artifacts of ongoing fermentation. So I asked the question, is it reasonable to expect the concentrations measured in faeces to tell you the level of exposure to the colonic mucosa? And my contention would be only if it's marked differences would it be of any relevance. So just to show you some data on this, this is studies done by a PhD student of mine last century, in which he was infusing butyrate into rats. We had this model where we infused it into distal colon. We're looking at carcinogenic mechanisms, and despite giving 80 micromoles 5 times a day, this poor student came in 5 times a day for 6 weeks to infuse these rats, and when you took faeces, you couldn't find any difference in short-chain fatty acid content in the faeces, despite all this being thrown into the lumen. And we knew, because of the effects of it, that it was actually getting into and affecting the mucosa. Then if we come back to most recently this century, that in an example of a study where in patients with IBS we fed them all their food and also supplemented the diets with either a non-fermentable or fermentable with non-fermentable fibre, and we could not show, despite increased fermentation evident on many other aspects, we could not show any difference in the fecal short-chain fatty acids. If we gave them twice as much, maybe we would. So it is a very poor reflection of how much fermentation is going on in the bowel. A study from the USA recently looked at transit time and the short-chain fatty acids measured in the faeces, and they found that the short-chain fatty acids, if you had rapid transit time, then the short-chain fatty acid concentrations were reduced, which has got nothing to do with how much is being exposed to the colon. So this is another factor in the mix. If you want to measure it in the blood, that's really problematic, because in this study done by Paul Gill in his PhD with us recently, he fed people, he was measuring all sorts of foods and the content of short-chain fatty acids, and gave them in a vinegar drink 26 millimole of acetate. And if you look at the pharmacokinetics of that, it gets absorbed very well, but you have to be right on cue to get the increase of it. So plasma ones are not terribly useful. They're very, very rapidly disposed of in the body. When he did the study where he did marked increases in the fermentable carbohydrates in the bowel, as well as the drinks, he was looking at the immunological effects of this. What he found was very disappointing, that some people increased their plasma levels and other people didn't. And in the faeces, there was some increase in the faeces because this was a very big dose, but it was pretty unimpressive. And so you can see that it really is not really reflecting. If we want to know if someone is having a lot of fermentation going in their bowel, measuring short-chain fatty acids is not the way to do it. And if you go then to, I'll just go to one disease group, and that's ulcerative colitis. This was a meta-analysis, and these are the butyrate concentrations. Now we've got one study in there, and we're on the far side of the curve, but you can see the fecal concentrations just go all over the place. And there was one that had incredibly, I don't know if that's high or low, but it was quite extraordinary. So that if you want to propose a theory that ulcerative colitis, the short-chain fatty acids are low, you can find papers to support you. And I can tell you, people publish papers there on this and quote the ones that are where it's reduced. Whereas the other people who want to say that this is toxic to ulcerative colitis, they quote the other papers. So, and this is the real problem with the whole test. So what about as a therapy? Now this is short-chain fatty acids. They're fantastic things. They can do everything. If you ever want to go in the lab and you want to get a few papers, just throw butyrate in something and measure something. It always does something, as I learned. And okay, if we want to do it, because they're so rapidly absorbed, taken up by cells, metabolized, we have to define our target location and then determine the delivery mechanism. Because you can't just take oral butyrate and expect it to go everywhere. So if you look at the colon, there have been many ways that have been proposed to do this. Let me go through a couple of them. If you want to deliver it to the colon, you can, if you give it just oral butyrate, if you can tolerate it, it won't get to the colon. It'll be absorbed very quickly. And in fact, in pigs, it makes their villi longer and they get fatter. So some people put butyrate in the pig food. And tributylin is one way which doesn't get absorbed and gets broken down in the colon, but it's a lot of capsules and apparently not very unreliable. People have coated butyrate and short-chain fatty acids in with things like you drag it, the pH release mechanisms, microencapsulated it with various things to give a slow release or a fermentable coating, and you can see here that most of these studies, there are single studies, very small numbers, and nothing definitive you can take home with you. What about doing it by giving lots of fibre? Now, it's best to produce it in the bowel, and what we need to do if you want to deliver it to the colon, it's not a matter of just giving fermentable substrate. You've got to get that fermentation going on all around the colon. And a combination of non-fermentable and fermentable fibre is the way to do it. That was based upon studies from last century and a recent study studies that were done in Nottingham as well as our own. And in ulcerative colitis, you got the problem that a study by Sally James with us several years ago showed that people with ulcerative colitis don't ferment as well as others. So you've then got that problem these are factors which need to be sorted. Then the most exciting part was a esterification of short-chain fatty acids to something else. And so if you put it onto resistant starch, you've got resistant starch which will generate short-chain fatty acids. But if you stick a whole lot of butyrate and acetate on it, you'll get a super dose. This was developed in Australia with the CSIRO, and it never quite got off the ground. It was being produced when it went out of patent by an American company, but they've stopped producing it because it's too hard to do apparently. But you can do this. You can get the levels in the faeces up. You can get the levels in the blood up. You can reduce tumorigenic events if you give people very high doses of red meat. But I'll just show you some. We recently did a study in collaboration where we produced food, which these things stink as well. But our research chef was able to make food that you could actually eat, and the plasma concentrations of butyrate and acetate and acetate and butyrate were phenomenal. We've never seen this before. And the blood pressure went down because in animals, short-chain fatty acids are good for hypertension. So this was great, except we can't get it now to do further studies. There have been some studies where propionate has been esterified onto inulin, but that's all been in the diabetes literature and the problems really are these organoleptic properties, which I love that term, and it just means the taste and smell of it are terrible, and it's really, really hard to use and to implement. And you also may get high toxic concentrations. What about enemas? Well, that's the easiest way to get it in. And diversion colitis, there was initial, Wolfgang Schepach's initial study excited everyone when he could fix diversion colitis with short-chain fatty acid enema. But unfortunately, there have been one observational, 2 randomised controlled trials, very variable results. And in ulcerative colitis, there have been also 3 studies which have been rather disappointing with the enemas. And the problem is, I can tell you what the problem is that you have to give it 5 times a day in rats to have effects on the bowel. And I'm sure in humans the same, because what you do is you get little bursts. You may be toxic when you first give it, and then things work and then they stop working. And doing it twice a day is just not enough. And what we showed in the study on the right-hand side there was that if you gave it 2 times a day, it didn't change aberrant crypt formation in rats given a carcinogen, but it did work when poor Cynthia went in 5 times a day for 6 weeks to infuse it. So it's never going to make it. If you put your patients on 5 times a day enemas, I think the patient might go to another doctor. So this whole story is a story of great promise and great problems. That it's got unrealised potential. It's been rediscovered many years. The number of times I've heard talks about this new thing, we can produce all these things with short chain fatty acids because they haven't read the past literature. It goes on and on and on, and it doesn't seem to go far from there. Its problems as a diagnostic test is the standardisation, the interpretation of levels, the timing of blood tests. Problems as a therapeutic agent is getting it where you want it, the toxicity of it, and the fact that it smells and doesn't taste good. And the problems of funding, of course, is that you can't patent these unless you patent the delivery mechanisms, and most of the information we have is underpowered and preliminary. And so I conclude by saying no value in diagnostic tests, an untapped resource, but it seems to be going nowhere as a therapeutic agent. Thank you.
Thank you very much for this, I would say, a bit disappointing presentation. Not about the quality of the presentation, but the message. Are there any comments or questions in the room?
Just a brief question. I mean, you've said that it's very difficult to measure the amounts, but of course, people have tried to measure the relative proportions of short-chain fatty acids, the Valeur criteria, for example. Would you like to comment on that?
Yes, well, some substrates will produce more butyrate, and resistant sites are going to be more butyrogenic. And if you so by measuring it is not going to help you. But if you know that is the case and you really want to get butyrate into the bowel, you would choose your substrates and your dietary substrates for the bacteria. Choose it carefully. But whether there's any value in that, I don't know, because butyrate is the one that everyone says does all these things, but in fact acetate and propionate do similar things. They just have been lost a bit in the detail. So I don't think that's a great value.
Excellent, Peter. I have a clinical question. You know, a lot of papers talk about the positive effects of short-chain fatty acids in cancerogenesis. So a lot of clinical studies. So, given all these problematic issues, how reliable is this proposed connection? I think
we know that from the studies we did last century, that the butyrate infusion in the bowel does inhibit the standard adenoma carcinoma sequence. And so what you want to do is to get methods of delivering the carbohydrates, the fibres, which are going to get fermentation right around the bowel. And if you come, you know, we're going to talk a bit more about this tomorrow. So yes, it does prevent, but measuring the short-chain fatty acids is not useful. Other things, there was people who have tried to use butyrate as an anti-carcinogen for breast cancer, but I don't think they ever worked out how to get the butyrate to the breast cancer, because rubbing it in was very antisocial. So, you know, this is these are the issues, and if you can anyone can solve them.
Hi, Peter. I remember vividly those last century, a lot of the butyrate work, and just around the time when all the enemas were being administered, there's a lot of data in the IBD literature about low levels in patients with IBD. So going back now, are you saying that all that information was largely inaccurate? Because a lot of the excitement was generated about demonstrating those levels and trying to find a therapeutic approach by administering with enemas or other things.
Yeah, it depends on what you want to look at. There are studies which have shown extremely high levels in ulcerative colitis, and it may be toxic in that sort of situation. What worries me about enemas is you give a really big dose, usually 80 millimoles or 60 millimolar of butyrate, and you might be doing a bit of toxicity. Then it has its other effects, and it's a problem. And so I don't think that excitement was a lot of artifacts as well. That's what my point is, that we have to be very, very critical of the measurement levels.
Maybe one very quick question.
Yep. One methodological question to start with is to maybe leave away concentration measurements and look at quantitative output measurements, because for that you have to know that fecal contents leaving the small bowel are isotonic, that have 290 milliosmol. The colon does not have the ability to concentrate. So whatever amount of short-chain fatty acids is produced and escapes absorption, then obligates fluids to remain in the colon. And then to this, the accompanying cations come with that. We have published that in JCI ages ago. And so what is really important if you want to do it quantitatively is to look at outputs. And then within the whole output, then there might be different relations between individuals.
Yes, and we've done that by measuring fecal output and then looking at the output, and it doesn't make any difference. It still does not reflect how much fermentation is going on.
Definitely not.
And that's the problem.
Okay, thank you very much. And this brings us to the last presentation of this before lunch, which is about diagnosis of small intestinal bacterial overgrowth, current and future options, by Satish Rao from Augusta in USA.
Thank you, Kristin and Daniel and Mark, for this kind invitation. I need to moisten my mouth. It's very dry up here. I don't know how you guys are sitting in. That was a riveting discussion on a very interesting topic, and I'd like to thank the previous speakers, Heinz and so on, for that trend-setting guidelines. So let's see where we are with my presentation. So my objectives today are to take this much more clinically focused approach, because almost all of you are clinicians, not all, but I think that's what you're here for, and you're really trying to see, well, what am I going to do today in my practice? I think somebody really asked that question so beautifully after Heinz's presentation too. So I'm going to focus on the diagnostic tests. I prefer the term breath test than hydrogen breath test. Heinz, I think you need to change this approach, because as soon as you start putting one gas and you start thinking, is methane relevant? Is hydrogen sulfide relevant? Maybe there are other gases out there that we haven't picked it up, and I'll show some data briefly on that too. So I think it's important that we need to really look upon this as breath tests for SIBO diagnosis. Then we'll talk of duodenal aspirating culture, and we'll talk about some of the new tests. I think somebody asked really, is there something else we can do? Yes, I think we are there, very close to it. And briefly, I'll touch on the ACG guidelines. So bloating, very common problem. You all recognize this. I really like this study by Bill Che's group, which asked a simple question to about 88,000 Americans. Do you have bloating? In the last 7 days, 14% said yes. And there are several demographics, women, Latinos, age under 60. And importantly, about almost 60% never sought care. So this is highly prevalent in the population. Not necessarily everybody seeks medical care. Now let me illustrate the rest of my talk using this case. A 67-year-old engineer came to see me with a history of Raynaud's, GERD, joint stiffness, 18-pound weight loss, severe postprandial bloating, and intermittent diarrhea. You can see I've set the stage already. Denies any blood, is on medications for blood pressure, lansoprazole, PPI for reflux disease, it's a stool softener, and some multivitamins. And this is the very classic scenario. Has had 3 endoscopies, 2 colonoscopies, a capsule endoscopy, and 2 CT scans, and a stool exam and culture. For these symptoms, everything is normal. Patient still does not know what is going on. Doctor says, well, I've done your endoscopy, colonoscopy. I don't know what's wrong with you. This is true. Every day, this is the majority of the patients I tend to see as well. So what more tests? So which one? And sure enough, you're all familiar with this. This audience is very knowledgeable here. We did a glucose spread test. We used 75 grams. And between 45 minutes to 1 hour, patient gets diarrhea. Almost simultaneously, there's a beautiful rise in hydrogen and no change in methane for this individual. And yes, it's a positive breath test. There is no question of diagnosis, and you don't need any positivity, sensitivity, specificity, positive predictive value to show this. We all believe this. So what is SIBO? The ACG guidelines define this as the presence of excessive number of bacteria and, of course, for C4, fungus in the small bowel, leading to symptoms of bloating, gas, abdominal distension, nausea, abdominal pain, or diarrhea. But in addition to these symptoms, you need a test, a positive breath test, either glucose or lactulose per the guidelines, and or a positive small bowel aspirate with a colony count of greater than 1,000, 10 to the power of 3 CFU per ml. This is how the ACG guidelines have defined it recently. Now, why are we all not having SIBO? That's because we have a number of factors that protect us. The gastric acid is a very important factor. We produce a ton of acid that then floats into the small bowel. Then we have very good motility in the small bowel. The MMC, or the migrating motor complex, phase one is this quiescent phase 2 is this intermittent activity, and phase 3 is this robust migrating complex at 3 times per minute, 11 to 12 times and 14 times in the small bowel. In addition, we have very good barriers in the small bowel, mucus secretions, the tight junctions. The gut is the most immune organ in the whole body. And then we have a barrier, the ileocecal valve, that stops the migration of colonic bacteria physically into the small bowel. So we have a number of factors that innately protect us. But it is not uncommon that these factors are disrupted. And once it happens, then potentially you've set the stage for developing SIBO. So, if so, how do you investigate SIBO? Well, here are some of the methods that we can all try, right? We can get a good history and maybe use symptoms as a guide. And some people, at least in America, it's very popular, they use symptoms as a guide for treatments. In other words, they use an antibiotic as a trial to see if they have SIBO. So let's look at that. And then there are stool tests, particularly very popular in America these days. I don't know what it is in Europe. Everybody now comes with this 30-page document of stool tests. I mean, they find I'm relearning my entire microbiology through these tests. I mean, they have everything under the sun, every fungus. And then I usually look at that. I said, thank you. I put it away. And then after finishing the discussion, the patient goes back. Doctor, did you see that particular organism is high? I said, yes. What about that fungus? So, your entire discussion is based on that. Then you have your breath test, glucose and lactulose. Then you have the culture. And then we have several new modalities. We'll talk about that. Now, first and foremost is really when a patient is coming, we need some symptom questionnaires. I have not really seen this validated European one. I'd really love to really bring that copy. But we've done this validation long time back, almost 15, 18 years ago. We looked at these 9 symptoms. We did a prospective study where we validated this. And we looked at both frequency, intensity, and duration. And we've categorized them into these multiple subtypes, which are all published already. But now we've moved on. And I think somebody mentioned as well that probably an app. And we have already developed this app. So this is the app that I would like to share with you. We have done the normative data that we published or presented, not published, at DDW last year. This app has about 15 odd questions, primarily based on the original validation of symptoms. It asks, do you have gas? Rate its frequency, rate its duration on the scale I mentioned, and the severity is on a visual analog scale. Likewise, bloating and abdominal distension and so on. We are currently validating it in patients with SIBO and carbohydrate intolerance. And these are the normal values in healthy subjects, about 40 healthy subjects, I think, participate in that. So you can see even healthy people do get gas, right? We all have gas. We all get a little touch of belching and a little touch of bloating and so on and so forth. So this is the normal range. Now let's look at our patient group. Now this was a study. Enrique is in the audience. Ashkin from Turkey were all part of this study. These are the typical baseline symptoms that our patients with SIBO report, right? Pain, 80%, 84% cramping, bloating, etc. So how good are these tests? Can we really use this test to make a diagnosis? Sadly, the answer is no. If you look at this, where we looked at pain, this is SIBO, which is culture negative and culture positive. There is no difference. So symptoms are very poor predictors of the underlying pathology or pathophysiology. So sadly, they will not guide us. They are good to help us to get them to testing, but they're not good in providing us with that precision we need for diagnosis. What about using empirical antibiotic as a diagnostic trial? Now, there has been no study directly looking at this approach, but we can glean into this through the rifaximin study that was done as part of Target 3 or Trial 3 in the US for approval of rifaximin as a treatment for IBS diarrhea. So in this study, there were 2,579 patients, et cetera. I'll share the details in the next time. But what I think is important is really if you look at the symptoms, baseline and post-baseline abdominal pain, a number of days with stool type 7, bloating, and movement urgency, there was clearly some change of all these symptoms, but bloating was only one of the many symptoms that was assessed. This was primarily a trial of IBS diarrhea. And so it's a very complex study. I don't want to go into all the great details about the whole study, but suffice to say there were initially placebo responders. That's what we're going to focus on rather than this part of the study, which was much more complicated. But there were 46% responders in this initial open label study. So you might expect to get about half of your patients with IBS diarrhea symptoms. Please note, these are pain and diarrhea, not necessarily gas and bloating or suspected SIBO. In that kind of a group, you can expect a response rate of 46%. But once you add gas and bloating or suspected SIBO, I think we don't know the answer yet. All right, that brings us to one of the key parts of my presentation is briefly the glucose, the breath test, which I would like to currently use hydrogen methane, but maybe we need to add hydrogen sulfide, and I prefer the term breath test. And as all of you know, safe, non-invasive. Now there are home kits that patient can do at home. I would put a little caution here because I find the home tests are not fully reliable. Not every patient actually follows through the instructions. The instructions can be very confusing. Even in a very well-oiled machinery of our lab where we do about 1,000 breath tests a year, we have patients who come having had a good meal the previous day. Oh, what did you have for dinner? Oh, I had chicken noodles. I had a big bowl of Mediterranean salad. I said, very nice. And I had a large glass of cappuccino. You're done. You can't do a breath test. So, but this happens all the time. But it is time consuming. It's not very specific. There are false positives due to dumping syndrome, and we heard that earlier. And then the other important question is it detects only proximal, particularly the glucose breath test, and will miss distal SIBO, and they can be false negative testing. But on the flip side, it is very easy. By far, the most non-invasive tests a gastroenterologist can ever perform. I mean, look at all the tests we do with endoscopy and particularly with motility testing. Practical, objective, inexpensive, non-invasive, and safe. You're all familiar with this. I don't need to talk about it. But essentially, this I don't have to go through, but we at least now know there are 3 major gases that can be measured after being produced in the gut. CO2, of course, we already have. So hydrogen producers, there are the methane producers, and there are the hydrogen sulfide producers. Probably tomorrow, maybe Mark Fox and others will come up with another gas. And so I think what I would like us to all think about is think about the breath test as an evolution of testing, rather than something which is defined in point in time and that is it, we're set. No. That is how I view it. And then there's been very good discussion already about why methane is important. Here's another person who came to see me with gas and bloating, very similar to the previous guy. We did his measurement. Look at his hydrogen curve, completely flat, but symptoms, as you said, is very important. Severe symptoms of gas bloating and distension. What's wrong? There you go. Once you measured methane, you have the answer. If you did not measure methane, you would say it's a negative breath test, maybe hypersensitivity, right? That's how we're going to view it. So stay tuned. We will be finding more gases, and there will be more to learn. So let's not close the blinders on this. All right. Again, methane, here is a little from one of the large data series that we published, showing that it really adds up to 33% extra yield. Oh, sorry, here 33% was the positive yield in the glucose breath test, but it adds another 10 to 15% extra value to the overall diagnostic yield of breath test by measuring methane. And I'm sure with hydrogen sulfide, we'll probably do more. So when we do a glucose breath test in my practice today, this is how we really define it. We define a test as positive or negative. A positive test we give 75 grams of glucose and 250 ml of water. A positive test is defined as an increase in level of hydrogen of 20 parts per million. Although we published as 15, we have now revised this to 10 parts per million, or both, a rise of hydrogen plus methane from baseline of 20 parts per million. That is how today we define as a positive test. Or, and this is one important caveat, with regards to the symptoms, the only symptom that I particularly think is of important is new onset of significant diarrhea during the breath test. This is important because sometimes the sugar is being fermented so fast and gas transport is extremely fast compared to fluid transport that there is not enough time for the gas to remain in the gut to be absorbed and exhaled through the lungs. Therefore, you will get a flatter curve. You will not reach your 20 parts per million. You may be 15, 17. But if they get diarrhea during the test, that is a positive test in our books. Of course, negative is insignificant or no rise in hydrogen. Using these criteria in the series of 733 patients, we said that the positive yield was 33% for glucose breath test, 67% for negative test, and important that there were 31% of this population in Augusta had methanogenic flora, and about 6.5% of patients had diarrhea with no rise in increase. So these patients, if you only rely on breath rise, you will categorize these as negative. So please be aware that these folks also are important. With regards to glucose and lactulose, this is an ongoing debate, and I think we don't use lactulose in my lab for reasons beautifully discussed already by several of you. Yes, I agree, glucose is absorbed in the proximal small bowel. It has good specificity and poor sensitivity. It will miss distal SIBO and rapid transit, whereas lactulose, we've already heard everything. So what is an optimal threshold for breath hydrogen testing? This is another controversial area. Should it be 20 parts per million? Should it be 12 parts per million? And here we did a study based on our lab. We took 150 patients, and these patients had both glucose breath test and duodenal aspirate and culture. We used the culture as the definitive endpoint. Again, please know that there is not 100% agreement on that. But anyway, using that, if you see a 5 parts per million rise, you have sensitivity and specificity. If you have 10, this is that. And so ultimately, we concluded that if you really use the cutoff of 20 parts per million of hydrogen and or methane, you will get, of course, there were few people here, you're getting a sensitivity of 42% and a specificity of 85%, or a 20 parts per million will give you that. So that is how we concluded in this paper. But I think this is well supported by this very nice, meta-analysis that Losurdo and colleagues did. And so we'll just get to the bottom line here. If you use the 20 parts per million cutoff point for hydrogen you get a sensitivity of 54% and a specificity of 83%, which I think is very acceptable for this breath test. If you use 12 parts per million, yes, you have a slightly higher sensitivity and a slightly higher specificity. For lactulose, despite all the other data, here is a very beautiful data which actually shows it has lower sensitivity. Now, I was always under the impression it actually gave higher sensitivity and the specificity was lower at 70%. So clearly, it does not do well when in this meta-analysis. So I think this is very acceptable for this. Let's talk about aspiration. Again, this is done in different ways.
Satish, just one half a second, because I'm very happy for you to continue, but there are a couple of other things going on in the background. If anyone's here going to the live demonstration, that includes you, Daniel, then in 5 minutes the buses will be going. The Library of Artificial Intelligence session, which might be you, will officially begin now, but maybe 12:30 is perhaps okay. So please, if you want to move in that direction already, then please do that, especially if you need to get something from your room. But otherwise, we can stay here and enjoy the end of this presentation.
Thank you. I will finish within my time allocated. So for the aspirates, I think this is some of the things we use. We use a sterile system, a Ligori catheter, and a sterile setup. I think I'm not going to spend time on my video, which I think you can all go to this website. It's available on YouTube. We've demonstrated this and published this in the Video GIE journal. But what is interesting is you grow a whole host of aerobes and anaerobes and so on and so forth. Again, everything is published, and a lot of fungi. So a lot of organisms we can grow through these aspirates and culture. And in this prospective study, we found, I have a slightly skewed population, so I do not want you to take away that you're going to find a positive culture in 62% of patients. Mine is a skewed population. But anyway, in the study, we had 62% overgrowth, of which there were only SIBO in 25%, a mix of SIBO and C4 in 19%, and another 19% was C4. I use this quite